what adventitial sounds do. So if you think about it that way, then you realize that that should not be the first thing out of your mouth when you're making an assessment on someone's respiratory status. All right, so wheezing, again, that's a very subjective type of descriptor, and we can do the same thing that we've done for air exchange and retractions and put that on a scale. And so you can have no wheezing, you can have mild, you can have moderate, or severe, all right? Stridor, same type of thing, all right? Where's the problem with stridor? Okay, it's your upper airway. It's either in your, mostly in your larynx, okay? Sometimes it could be in your upper trachea, but most of the time when we refer to stridor, you're talking about your upper airway. And again, you can give the same descriptors to that. Crackles, don't quantify those so much. They're kind of either there or not there, and it's more important to describe where they are. They're in the right lower lobe. They're in the left upper chest. And what do crackles represent? Okay, it's fluid somewhere in your lungs. It could either be in the interstitium, it could be in the alveoli. All right, so it could be fluid. If it's fluid in the interstitium, what do we call that? Pulmonary edema, okay? If it's fluid in the alveoli, what do we call that? Pneumonia. And if it's fluid in, excuse me, it could be atelectasis or collapse of the alveoli, and that is atelectasis, obviously not specifically a fluid collection. But again, it helps to make a diagnosis and tell you why you have these sounds, or why you have this clinical state. What do coarse sounds represent? Okay, if y'all want to come down so you can actually participate, because that's what I need. I'm talking to myself down here. All right, what do coarse breath sounds represent? Well, but what is rhonchi? I mean, where's the problem? What are you hearing? Yeah, I mean, you're hearing, for lack of a better word, crap in the airways, right? I mean, you're hearing some kind of secretions, some kind of, secretions that your body needs to expel, and that's what coarse breath sounds are, yeah? All right, and what do you think about if you hear decreased or absent breath sounds? All right, but why? I mean, why would that be happening? Okay, you could have one lobe could be completely atelectatic to the point that you're not hearing crackles because you're getting no air movement in the alveoli. What else? What if the patient were requiring PIPs of 35 to 40 bagging in order to ventilate them adequately? Yeah, pneumothorax, okay? So, once again, if you have decreased or absent breath sounds, you could have a pneumothorax. You could have atelectasis to the point where you're not getting any alveolar openings, so therefore you're not hearing crackles. All right, it could be, what about fluid around the lung? Yeah, if you had an effusion or an empyema, okay, you're not going to hear good air exchange or, in that section, whatever part's kind of impinged, all right? So once again, the adventitial sounds help us make a diagnosis as to why we're having, whatever problems we're having on a clinical basis. Okay, saturations, again, speaks for itself. You use the pulse oximeter, and again, that's quite objective, hopefully, and the same with the respiratory rate. So we put all these things together so that we can understand our patient's respiratory status. So again, you're looking at two things. You're looking at the ventilation and you're looking at oxygenation. And for the most part, in peds, it's very easy and usually appropriate to think of them as two completely separate processes, all right? Obviously, there are some interactions, but if you think about it as, if you think in your head, I need to assess my patient's ventilation, and then I need to assess my patient's oxygenation, it usually works out just fine because the two processes differ, and the ease and the ability to do it and whatever the pathologic process is can have an effect that's very different on one or the other. Let's see, what else? If you had to pick just one of these 5, and you guys can't see them, all right, respiratory rate, air exchange, saturations, retractions, adventitial sounds, all right? And I told you, I held a gun to your head, and I told you that you could only assess one of the 5 of these, okay? Which one would you choose? And in other words, which one would tell you the most about both ventilation and oxygenation if you only could look at one of the 5? Okay, air exchange, all right? Because the presumption is if you have good or adequate air exchange, all right, you have an adequate tidal volume, okay? And if you have an adequate tidal volume and you're able to move air, in and out, that, the process of adequately having a PCO2 that is desirable, or at least life-sustaining, and also of, being able to move the oxygen effectively is there. And obviously, it doesn't tell you the whole picture, okay? But it is, if you have to choose one of them, all right, that should be the first thing you assess. It should be the first thing you report, and the first thing you put your money on, okay? So when do you start doing a respiratory assessment? Yeah, when you walk in the room, okay? We're doing multiple things at the same time, right? You're kind of looking at the patient's mental status, yeah? You're looking at their respiratory status, and you're looking at their circulatory status from the moment you start approaching the patient, okay? You can do many of these things without even, having to use your hands or your stethoscope or look at anything else when you're just doing a general overall head to toe with your eyes, okay? And so take advantage of that, all right? Even though you're not thinking about it, you're looking at their ease of breathing. You're looking at their, tidal volume by assessing, what their chest movement is. Is it, are they panting with very shallow breaths? Or are they, really working hard and, trying to take in adequate tidal volume, but it's a lot of work for them? Are they pale? Are they, limp? Are they cyanotic? I mean, you can make all these things, even before you look at a sat monitor or count their respiratory rate, take a blood pressure, or, do a blood gas, okay? So when you think about a respiratory assessment, remember that you're trying to do 2 things. You're trying to first, what is my patient's physiologic status right now? Do I have adequate ventilation? Do I have adequate oxygenation? And then secondly, can I identify that or classify that process as to why it's not normal, okay, if it's not normal. And, not so much a definitive diagnosis, but something that lets you aim and institute a treatment so that you can improve their physiologic status, okay? All right,